Everyone, today's video is about surgical airways at a broad, kind of general surgery level, as opposed to a more granular level like you might expect from, for example, an ENT surgeon or someone like that. So, big picture, we're going to be covering the two basic types of surgical airways and their indications, the anatomy that goes into the decision making about placing these tubes, a little bit about each different technique, some potential complications of surgical airways, and then a bit on post placement management. So, just in brief, it's all in the name in medicine. The two main types of tubes we'll be talking about are the cricothyroidotomy tube, or a Cric, and the tracheostomy tube, also known as a trach. So, before we get into exactly what those means, it's important to review some anatomy. And this is, for example, head up here, direction of the foot down here, and this is just a picture of kind of the upper part of the trachea. And so here we have the shield-shaped thyroid cartilage. Down here, that first ring is the cricoid ring. In between the two of those, we have the cricothyroid ligament or cricothyroid cartilage. And then down here we have tracheal rings. This would be, for example, tracheal ring 1, tracheal ring 2, and tracheal ring 3. Of course, it's also important to remember that there's more than just the trachea found in the neck, right? And so, for example, the thyroid and some of these blood vessels are probably the biggest barriers to getting towards the trachea. And so, if we're talking about the thyroid and the cricoid ring, that's kind of above where the thyroid typically sits, and then tracheal rings 2 through 4 are a bit below it. And so, if we're talking about the two tubes or the two types of surgical airways, the first was the cric, right, or cricothyroidotomy. And if we think about that, the cricothyroidotomy stands for the cricothyroid membrane right here between, again, the thyroid cartilage and the cricoid ring. And so a cric involves dissecting down and making an incision in the cricothyroid membrane here to gain access to the trachea. Whereas a trach, on the other hand, um, is down in the tracheal rings. Typically, tracheal rings 2 through 4 is about the level you're shooting for. Remember, if this was 1, 2, 3, you'd be shooting for somewhere in this range, so a bit lower in the neck is the typical spot for a tracheostomy. All right, so why would we use these surgical airways? Well, the first, we'll talk about the less common one first. So, a cric, this is quite a rare procedure. This is really only used when anesthesia or somebody's trying to intubate a patient and they are failing, and the patient's rapidly decompensating or desatting, and you just need to get access to that airway as soon as possible. And it makes sense that a cric would be used for this, in particular because remember how close it is to the thyroid cartilage. Remember that thyroid cartilage is that large shield-like cartilage in the neck, especially prominent in males, a lot of times called the Adam's apple. And that's probably the easiest landmark just to palpate in the neck. So if you're in an emergency, stress, trying to quickly get access to an airway, that's going to be the easiest thing to find in the neck. That's going to allow you to gain access to that airway. However, the problem with the cric is that it's very high relatively in the neck and high in the trachea, where it's a little bit narrower, and long-term use of a cric could potentially lead to some stenosis of the trachea itself. So once a trach is placed, you're usually thinking about converting that over to a trach within 24 to 72 hours is the common teaching. And then a trach, the common indication for that is usually failure to wean from a ventilator. So remember, most of our patients on a ventilator have an ET tube or an endotracheal tube, just that plastic tube that we place in patients temporarily for surgery or in the ICU if they're needing ventilator support. They have one of these sticking out of their mouths. And while they're, a nice reversible source of airway access, the problem with those tubes are manifold. You can imagine you couldn't really live your life. You can't discharge a patient with an ET tube, and that's because it's very uncomfortable. It's constantly stimulating the uvula, stimulating the gag reflex, causing a lot of pain and irritation to the back of the throat. And then it's also, if we think about just like with blood vessels, a long, narrow tube is hard to get anything through. And so an ET tube is a relatively long and narrow tube, and it's kind of like trying to breathe through a straw, which is very difficult and uncomfortable, as opposed to a trach tube, which is actually much shorter and fatter and easier for patients to move air through. All right, so a little bit about basic techniques. Remember, we're talking about a cricothyroidotomy here. This is the emergency situation. You're trying to slash down through the neck and get access to this airway as fast as possible because the patient is actively dying in front of you because they can't oxygenate. So in this situation, this is a first I'll discuss this kind of stylized version of the trachea I've created. This is like you're on the side of the patient, just like you would be if you were performing an operation or a procedure. So the head direction's up here, the foot direction's down here. This is the representing the thyroid cartilage. It's a bit bigger. The first ring is the cricoid. Then we have tracheal rings 1, 2, 3, and 4. So remember, a cric really focuses on that thyroid cartilage, the cricoid ring, and then that cricothyroid membrane between them, which is where you're going to be eventually getting access to the trachea. So remember, emergent situation, you don't have time to be precise, fancy, and measure things. You're just going to make a rapid longitudinal incision at the skin. This is because if you maybe make it in the wrong spot, you can just extend it in the direction up or down that you need. You don't have to keep making separate incisions if you're in the wrong space. Also, there's some superficial veins that tend to run in the skin of the neck that if you go vertical, you'll definitely avoid. If you go horizontal, you might run into, especially if you're in a hurry, and then that bleeding will obscure your field. So you palpate the thyroid cartilage, make a vertical midline incision, and you're slashing down sharply to the trachea, trying to find this cricothyroid membrane. Once you get down there, you're going to make a horizontal incision through that space, and then you stick something else through that incision to keep it open. A lot of techniques describe flipping your scalpel over, sticking your handle in there, and then rotating your scalpel this way so it kind of stents the opening there. Other people will tell you to just push a bougie down there. Some people will say put your finger down. Other people a trach spreader or a trach hook. I would probably do a bougie. Um, that just seems like a nice, safe way to that doesn't involve sharp objects to shove something to maintain the tracheal space, and then you can very easily slide an ET tube over top of it into that space, and that's typically a size 6 ET tube that's used in this situation. Once that tube's in, immediately have anesthesia or respiratory therapy or whoever hook you up to the circuit. Make sure you have end tidal, and once you've got that airway in place, you can start securing it. And then remember, a cric is temporary, so you should be thinking already. Okay, when do we take this patient to the OR? When we're going to be converting that to a tracheostomy. All right, so that was a cric. Now we're going to talk about an open tracheostomy. So this is a more typically an elective type of procedure. Elective is not really the right word for it, but it's certainly not that emergent crashing patient setting where we need long-term access to the airway. Yeah, for example, if a patient can't wean off a ventilator, or maybe they have a cric and we're converting it. So this is the same setup. So head to foot, thyroid cartilage, cricoid cartilage, tracheal rings. And remember, the tracheostomy, that's all about the trachea. So we're actually aiming for tracheal rings 2 through 4, roughly, as our level. So a good marker for that is to take 2 finger breaths above the sternal notch and to make a horizontal incision at the skin. Then you're going to carefully dissect down to the tracheal rings. Um, Again, aiming for rings 2 through 4. Classically, and we'll talk about this more later, if you go too high, you get subglottic stenosis. If you go too low, you run the risk of a tracheoinnominate fistula. Once you get down here and you found the rings you're interested in, you want to place some stay sutures. That's usually described as a figure of 8, where you go in and out, right? A stitch on either side of the third tracheal ring. These stay sutures can be used to hold up that cartilage when you go to put the trach in. It's getting a little bit messy. Um, and then, since you're doing this procedure in somebody that already has an ET tube in, you want to make sure they take the cuff down on that tube so you don't accidentally injure that cuff. And then you're going to make most typically what's called an H-type incision at about the level of the third tracheal ring. And what is an H-type incision? I had a lot of trouble understanding that at first. But typically what you do is you make 2 incisions horizontally in the space between the second and third ring, and then the third and fourth ring. And then those are typically done with the scalpel. Then you typically take a scissors and connect the two. And you can see how that makes an H here, and that creates a nice big opening here for you to insert the tracheostomy tube into. Once you've made this incision, you're going to have them back the ET tube up out of the way, and then you pull up on those stay sutures that you placed on either side of the ring, and just gently glide the tracheostomy tube into the correct position. Once again, you want to hook that up to the ventilator, confirm your end tidal, and then suture it to the skin in place. Typically at our institution, we use an 8-0 Shiley as our first tube for an open tracheostomy. All right. Slight modification of this technique is the Perc trach or the percutaneous tracheostomy tube. You start very similar to the open tube, where you're making that horizontal incision roughly 2 finger breadths above the sternal notch because you're shooting for that same place. But instead of dissecting down all that way, actually you just bronch the airway. So you're looking through the ET tube down here at the tracheal rings. Pull back the ET tube to a sufficient position to allow space. Then you're actually going to take a needle down through the skin and poke through the trachea at somewhere around this area. And you're going to visualize that with a bronchoscopy. Once you've got the needle in the right place, you just do a Salinger technique like any other, where you pass a wire through that needle to hold your space. And then over that wire, you're going to pass dilators and eventually your tracheostomy tube and secure it in place. A nice pearl I like for this is really a pearl related to bronchoscopy in general. And that is that you want to know how to orient yourself when you're looking in the trachea. So a trachea typically looks something like this. The key here is to know that this is anterior and this is posterior. And you can tell because you have these kind of C-shaped rings of cartilage, and then it's flat here in the back, a flat muscular area, and that's posterior. So just a good way to orient yourself. If you were looking for a needle coming through, it'd be coming through the top up here. All right. So what are the complications of having a long-term surgical airway? And this is really related again to tracheostomy tubes or trachs because those are the ones that you leave in long term. And this is related to placement and why we place it between rings 2 through 4. And it's thought that if you place it too high, that you have the risk of subglottic stenosis. So the trachea up higher, kind of right under the vocal cords, is a little bit narrower. And that tube can rub against the sides and over time narrow that and stricture down your airway, which is, of course, a problem. On the other hand, if you go too low, there you run the risk of developing a tracheoinnominate fistula, or a fistula between your trachea and your innominate artery. So if we draw that out, you can imagine kind of an AP view, right? So this is the trachea. You got your some tracheal rings, and you've got some large blood vessels coming up out of the heart that are branching. And one of the big ones branching to the right side of the body is the innominate artery or the brachiocephalic artery. And it actually passes directly in front of the trachea. And so if your trach tube is too low, it can actually be rubbing into the trachea right behind the artery and eventually create a fistula between these two structures, which of course leads to massive hemorrhage into the trachea and usually very quick death. So if the tube's high enough, even if it erodes a little bit forward, it's not going to run into that massive artery. The other good thing to know about tracheoinnominate fistulas is the treatment for them. That's a common PIM question. So if you have a tracheoinnominate fistula, first, you're lucky if you catch it in time to save the patient. You want to try to usually hook your finger inside of the trach hole and pull up to put pressure on that artery and stop the bleeding, and then rush them to the operating room. And the surgery that you do is you actually resect the brachiocephalic artery and you do not reconstruct it. That's the classic thing. They'll ask you, do you want to reconstruct this? Maybe with some uh, replacement like plastic or Dacron or something, and you do not want to do that because that's an infected, dirty field because of the communication with the trachea. The classic teaching is that that graft will get infected and then blow out again, and then the patient will exsanguinate. So surprisingly, people do really well with that artery ligated, and that is the classic treatment for that fistula. All right, so just kind of breeze through a few post-placement topics. When can you change the trach? Trach tubes are not permanent. They definitely need to be changed. They get dirty. They get granulation tissue on them, etc. And we typically wait around 5 to 7 days to change an open tube, or for a Perc tube, usually 7 to 10 days. It's important that when you're changing a tube, you want to have both the size tube that you currently have and then the size below it, just in case it's a bit of a tight fit. To get down there, you can always go down to that slightly smaller tube. So, for example, a 6.0 tube instead of an 8.0, just in case you can't quite force the tube down into where it needs to be. It's important to always have a bougie. Again, that's just kind of a long rubber tube. To have a bougie available in case you make a false tract, have a hard time getting that tracheostomy tube back in there when you change it. You can use that to make sure you get in the right space and then slide the tube over top of it. And then finally, decannulation. That's just when you're done with the tube. When do you know you're done? How do you step down and take it out? This is usually a topic for respiratory therapists and not surgeons. But if you're ever on a service where you do end up taking out somebody's trach tube, it's important to just put an occlusive dressing over it, kind of like you would for a chest tube, usually just a gauze and a tegaderm, and leave that on for a couple days. And actually, that tract seals up really quickly, just like when you pull a G tube or a J tube. So it actually doesn't take that long to keep the dressing on. All right, so kind of a whirlwind topic. These videos always seem to end up like that, unfortunately. But to review, we talked about the two types of surgical airways. You have your cricothyroidotomy tube, or a Cric. You have your tracheostomy tube, or a Trach. The Cric is pretty rare. It's used in emergency situations. The Trach is really good, kind of the classic standard in long-term surgical airways. Um, but make sure you put it in the right place, because if you put your tracheostomy tube too high, again, you can get stenosis. Too low, you can get the bleeding from a tracheonominate fistula. So you're really shooting for rings 2 through 4. Of course, the marker on the skin is usually about 2 finger breaths above the sternal notch, or kind of 2 finger breaths below the thyroid cartilage. All right, that's it. These videos are for educational purposes only. Do not use them to diagnose or treat any diseases, and we will see you next time.